The auditorium where we reside this morning bears the name of Cal Souther. Mr. Souther was a generous friend of the city of Portland and our medical community. As a part of his commitment to the advancement of knowledge in medicine, he endowed this lecture series. We thank his family once again for the privilege of hosting this event. There have been 21 world-renowned speakers who have visited this room under the sponsorship of the Souther Foundation. None are more respected or as well recognized as this morning's guest. There are several special places in the medical world that are uniquely famous. One such center is in New York City. When I have a particularly tough urologic oncology problem, I think of Memorial Sloan Kettering first. When I call there, I ask for Bill Fair. We are very happy to have Dr. William Fair with us today. Bill currently holds the Florence and Theodore Baumritter Enid Ansel Chair of Urologic Oncology at Memorial Sloan Kettering Cancer Center. He is also the director of the Prostate Cancer Diagnostic Center at Memorial and is professor of urology at Cornell University Medical College. As you might guess, his CV is weighty, about the size of a small telephone book. I will mention only a few of his recent and past awards that have highlighted his career. He was a 1998 recipient of the Ferdinand C. Valentine Award of the New York Academy of Medicine and the Research Career Development Award in 1972, both for general medical achievement. And the Hugh Hampton Young Award of the American Urologic Association, its highest award in 1980. It is my pleasure to introduce Bill Fair. His title lecture this morning is Complementary Medicine, an Academic and Personal Perspective. Bill? As Bill comes up, one brief announcement. House staff and interested physicians are welcome to join Bill in room 12 in the West Pavilion. That's the far end of this complex. Room 12, after this lecture, will convene about 9:20 or so. And one additional announcement, do we have the CME forms? Okay, there are CME forms. They weren't available to you when you might have come in. They will be available to you when you leave. Please fill them out if you wish to gain CME credit for today's lecture. They will also be available at the noon lecture. Bill?
Thanks, Jerry. Well, it's a pleasure to be back here. Is this thing working? The lavalier? It's a pleasure to be back here and want to consider myself honored to be one of the very few repeat performers at the Souther Lecture. And Jerry didn't mention, but he and I started a long time ago at residence at Stanford, and it's a friendship that I treasure very deeply, and it's nice to be back here again. Rather than giving a particular talk on urologic oncology this morning or on prostate cancer especially, I thought I would share with you some of my thoughts on the aspects of healing that are generally not covered in conventional medical discussions. And I've entitled this An Academic and Personal Perspective. And you may think this is a bit unusual coming from a place like that's known for its expertise in surgery and chemotherapy and radiation. But I'd like to take you through some of the things that I went on my own personal journey 4 years ago, came down with colon cancer, and then went through a series of operations and a year of chemotherapy, and actually finally got to the point where I had recurrence and exhausted all of the available treatments and was faced with the possibility of taking some more experimental chemotherapy and some more radiation and surgery. At this point, I was fortunate enough to go out to Michael Lerner's program at the Commonweal in California, and it's a cancer patient program, basically just 8 people, and spent a week out there, and really came to the realization that there's more to life than just spending as much time as you can on Earth, and there are other things that one should consider in what makes a full life. And as a result of this, elected not to go with the experimental therapies, but decided to do something, because one of the worst things about being a cancer patient, and many of you in the audience may share this, is the actual impotence that one feels. Not the Bob Dole kind of impotence, but the fact that you, the fact that I think particularly if you're a doctor or used to running a business or an attorney or something, where you were calling the shots, all of a sudden you're the patient, and somebody comes along and says, just be quiet and do things and we'll take care of you, and that really is an unsettling concept. So I felt it was important to try to do something, and obviously, like I think any cancer patient, once you found out that you have this, you're immediately besieged by friends and well-wishers giving you 1,000 different pieces of advice about this alternative medicine or that alternative medicine, and it's very confusing, but I thought I would look into some of these things and see what scientific basis, if any, existed. And I was quite pleased and delighted, actually, to find out how much data were there. So I'd like to share some of this with you and give you some of my thoughts on the whole area of where complementary and alternative medicine stands currently. And some of you know, the urologists probably know, that recently the American Urological Association, much to my surprise, started a committee on complementary and alternative medicine, which I chair. The Office of Alternative Medicine, which used to be a small office in the National Institutes of Health, has now been upgraded to a center on complementary and alternative medicine, and I'm on the cancer board of that program. And it's really encouraging to see the interest and enthusiasm for this, and more importantly, beginning to look at these things in a very scientific and objective manner. So, as you will see, as we go on this morning, what I'll try to do is develop the rationale behind these things. I certainly can't cover all the options in complementary and alternative medicine. You'll hear me use the term CAM, C-A-M, because that's what the National Institutes of Health has finally decided. I don't think this lavalier is working. Has finally decided it will be the appropriate term, and the interest in CAM, I think, is growing. And since we can't get an agreement whether it's alternative or complementary, we use the term CAM. And I'll tell you why I don't like alternative in just a minute. Again, I said this is an academic and personal perspective. My background has been at Stanford University, where Jerry and I met, in Washington University in St. Louis, and then Memorial Sloan Kettering, and none of those institutions are thought of as sort of being in the forefront of alternative or complementary medicine. So it's been strictly standard medicine, if you will. That's been my training, and I think that it's as much a surprise to me as anyone else who knows me that I have found out as much about the validity of some of these techniques that I did. I meditate and do yoga every day. I don't do yoga every day, but I meditate every day. If someone would have told me 4 or 5 years ago I've been doing that, I'd say you're absolutely crazy. But I found it adds so much to my life. Okay, we'll start off. This is a figure that I'd like to start off with. It was published in USA Today a few years ago, and it's entitled Prostate Treatment Concerns. What they did, this was US2, which is, I noticed there's a man-to-man support group here. That's the American Cancer Society. US2 is a similar organization. And what US2 did was take a poll of men with prostate cancer and ask them what were their major concerns. And as you see up here is slow the cancer and extend life, followed closely behind by improving life quality. Nowhere on that list is curing the cancer. And to a cancer patient, that really isn't as important as these other things. No one's going to live forever. So if you can slow the cancer, extend life as long as possible, and maintain the quality of life, is it really important to cure the cancer? When we go to medical school, we're never taught we're going to cure diabetes or cardiovascular disease or arthritis. It's control. It's only cancer which has such a fearsome implication, the word, that we think we have to cure cancer. And obviously we should cure it if we can. But I'd like to at least introduce you to the concept that perhaps control rather than cure may be a reasonable option in many cases of cancer. I like this to start off with this also. Dr. Murray Brennan, John, if you're still here, you remember Murray well. Can you focus that, or do I focus it down here? I guess. Thank you. Dr. Brennan, who's the chief surgery at Memorial, gave me this quote, and it's from John Hunter, father of modern surgery, and goes almost 300 years ago now. Surgery is like an armed savage who attempts to get that by force, which a civilized man would get by stratagem. Now, in John Hunter's day, they didn't know about chemotherapy and radiation, so that's why he used surgery. But I think that any of those can be put up there, and it underscores the fact that our treatment carries with it the risk of harm, not only the hope of cure. Talking about unconventional medicine, I mentioned that some of the terms used are alternative. I don't like alternative because that means that you're using this in place of standard medicine, and I don't believe that's the way to go. I think that we should use standard medicine as much as possible. One can't deny the advances of modern medicine, and I look at what we're talking about today as complementary or an adjunct to these standard approaches. Why is unconventional medicine important to physician? Well, the numbers are very interesting. This is a study from David Eisenberg at the Harvard Center for Alternative Medicine Research, and it was published in the New England Journal of Medicine in 1993. This study done in 1990 showed at that time an estimated 61 million Americans were using alternative medicine, as they described it, and 72% of those who were using it, 7 out of every 10 people using it didn't tell their doctor they were using it. You can appreciate what the potential for harm this could lead. It was also interesting that the people in whom the highest use of alternative therapies were found were not the poor or uneducated or the older people. It was a group between 25 to 49 with a higher educational and a higher income level, especially those making over $50,000 a year. Now, recently, the Harvard Center has updated these figures and published them last year in the Journal of the American Medical Association. And in comparing the number of total visits to practitioners of complementary medicine in 1990, which was 427 million, found that actually 629 million in 1997 for a 47% increase. At the same time, over here on your left, given in the blue bars, visits to primary care physicians actually decreased a little bit, so that patients are visiting by more than 50% alternative medicine practitioners more frequently than they are visiting primary care physicians. The cost of the professional services, and it's important to keep in mind that these services for most states are not covered by insurance, so that this is out-of-pocket expenses for the most part. In 1990, it was $14 billion. 1997, $21 billion, for an inflation-adjusted increase of 45%. And this is just professional services. The Wall Street Journal had an article last October where they estimated that the total expenditure on services and supplies for complementary medicine was now in the range of $50 billion a year. So it's a huge output. Now, the possibility is that the reason this microphone's not working because it was down around my ankles. Is that, let's see. Can we put that on now? Okay. Also, the most frequent users were obviously, as you might expect, people with chronic illness. And again, the same study documented the results almost identically to those done some 7 years earlier, that the majority of patients who use complementary medicine didn't let their allopathic physician know they were doing it. Now, if we think about the whole history of healing, recognize that in early medicine, healing was the province of the priests. It was not the physicians. The priests and the medicine men, the shamans, were the ones to whom people came to for healing. And in many primitive societies in Africa and South America, the idea of the medicine man still being the healer is alive and well. And I put here the term hexes because it's fascinating to read some of the stories about hexes and how this is an illustration of perhaps the impact of the mind on the body, that in these primitive societies, that if a hex is put on a person, as likely as not, that if a person's told they're going to die, as likely as not, they will die. And have you ever stopped to think that as physicians, when we give a prognosis to a patient, which I think for any residents in the audience we should never ever do, never tell a patient they have X number of months to live. First of all, we're not that smart. But secondly, that's just the same as putting a hex on a person. And it's even more powerful because it's coming from someone in a white coat who's supposed to be clothed in the aura of modern science and saying you have X number of months to live. And I think, again, as a patient, you appreciate that that is just the same as receiving a death sentence from a shaman in some primitive society. But as a result of, let me go back, as a result of the writings of René Descartes and others, but predominantly Descartes, I guess, this idea that there was a separation between the mind and body and the psyche and soma, or the spirit and substance, became more prevalent. And Cartesian philosophy holds then that Western medicine was concerned more with the body, and we've become a technologically oriented healing institution, if you will. We're always looking for the magic bullet in Western medicine. We want the one drug that's going to cure the infection or cure the cancer or take care of whatever we have, and we want to find out what is it that has the effect. On the other hand, Eastern medicine, and I'm not in any way an expert in Chinese medicine or Ayurvedic medicine, but I'm struck by the fact that Eastern medicine is more centered on raising the energy, if you will, which Western medicine we call the immune system, but the energy, the chi, the prana, whatever it is, within our own body so that our body can fight off disease. So you won't find in traditional Chinese medicine a specific approach for prostate cancer or colon cancer or diabetes, but it will be an approach to stimulate the immune system, what they would call qi, to allow the body to take care of this illness. And it's a polytherapy. It's not a one-shot approach. And that all of these approaches in the ancient medicines involve some lifestyle modifications, diet, exercise, so forth, herbal preparations that we tend to discount in this country. And I'd like to, during the course of this lecture, to take you through some of these things and explore with you what we know about these and what validity they have. Now, you notice I'm not talking about wearing crystals on your heads or copper bands around your arms or things like that. And these are the areas that I think we still don't have any good way of knowing whether there's any value in them or not. There's an awful lot of confusion, and there's a lot of people in the field of complementary alternative medicine that are purely in it to make a lot of money in unsuspecting people who are suffering from chronic disease. But I'd like to consider these techniques, and I think you may be as surprised as I was to know what validity exists. Certainly in the area of nutrition, there's a lot of emphasis, and I think most of us physicians have not been adequately trained in the area of nutrition. But for the urologist in the office, they'll recognize this. This is a prostate gland of a man who died of another condition, and he was in his 70s. And it's a normal prostate gland from an older man, with this one exception in the triangle here, which is blown up over here. This is an area of prostate cancer. And this is not a precursor of prostate cancer. This is prostate cancer. And this man had prostate cancer, but never knew he had it and died from other causes, and this was found only as a result of the autopsy. The interesting thing is, if one looks at this prevalence of histologic cancer, histologic, sometimes called microfocal or latent cancer, in the United States and Japan, they're identical. And as a man ages, the likelihood of having this histologic cancer increases. It's often been said, and I believe it's a truism, that it's not a question if a man will get prostatic cancer, the question is when. If you live long enough, basically you'll get it. And you notice here, in contradistinction to this one, the lines are superimposable. But this is the prevalence of clinical prostate cancer, or killing prostate cancer. And you can see there's a marked discrepancy between prostate cancer, clinical prostate cancer in the United States and Western Europe countries, again going up the older the man gets, and in the Japanese and the Pacific Rim countries, which is very much lower than it is in the United States. And that automatically raises the question, why is there such a difference? What's going on here? Why does this one graph show that the latent cancer or histologic cancer stays simply that, latent or histologic, where in the United States and Western Europe, prostate cancer is the most commonly diagnosed, the most commonly diagnosed cancer in men. And if you'll also notice here, this was done in 1990, the indication here is at age 30 or 40 that histologic cancer is not found. And this is what we thought up until about 18 months ago. This study came out from Wayne State, and what they did was the same kind of things that were done before, but except they looked at younger men who had died as victims of accidents and violence in Detroit, and were able to show that men between the ages of 30 and 39, 30% of these men had microscopic cancer in their prostate. And another 16% had prostate intraepithelial neoplasia, which we think, we're not sure, but we think is a precursor of cancer. And between the ages of 40 and 49, 60% of men either had obvious cancer on microscopic examination or this cancer precursor. And this is a phenomenal figure. So the question is, why is it that we have this latent cancer that seems to be so common on pathologic examination, and what is it that in many areas of the world this latent cancer is simply that? It's a pathologic curiosity. Why is the killing cancer in the United States and Western Europe so common? This microfocal or latent cancer is unrelated to race. We know that American blacks have the highest incidence of prostate cancer in the world, and yet there's no difference between black and whites in the United States in the interest in the amount of this microscopic cancer. In Orientals, there's the same amount, as I showed you. In Western Europe, it's the same throughout the world. So this idea that there are certain races that have a higher risk of cancer only applies to the killing or clinical prostate cancer and not the microscopic prostate cancer. And I said it increases with age, and at age 75, the incidence of 50 to 70% is probably conservative. So we have this conundrum. Microfocal disease is at least 3 to 5 times more common than clinical. It's been said, and again, it's another truism, many more men die with prostatic cancer than of prostatic cancer. And despite this geographic uniformity of microfocal cancer, there's a marked geographic variation in clinical disease. And one could ask, why this discrepancy? And one of the things that really adds to the confusion is some of the migration studies. And on your right are given some studies which show the incidence of prostate cancer in Japanese and Chinese men living in their homeland. Within one generation after migrating to the San Francisco Bay Area, and this, it's not just that San Francisco causes cancer, you understand. This is where the studies were done. The incidence of prostate cancer has increased 3 to 7-fold. That's a tremendous increase. There's nothing else like that we know of. 7-fold increase within one generation. It's astonishing. But why this discrepancy? Well, the two hypotheses that come to mind, there could be some factors that inhibit the growth of this latent cancer so that it always stays latent, or could there be some factors that in a subset of men stimulate the growth of this latent cancer so that it grows in some men and not in others. And if we look at, this could be any cancer, but if we look at from the time the cancers develop, the initiation or promotion, and this would be where we would find the latent cancer, to progression, we know in prostate cancer that from the time the first cell becomes malignant until we can detect that cancer, maybe as long as 20 or 30 years. And there are other parallels in colon cancer, not quite as well worked out. But a number of cancers, there's increasing evidence that the first abnormality, first cell becoming malignant or the first molecular changes that take place, may precede by many years the clinical development of cancer. So the question, particularly in prostate cancer, is that progression, not initiation, may really be the key to control. It may not be really important to know what causes prostate cancer. But if it takes 20 to 30 years for the tumor, once it started, to become life-threatening, I often say my dream, more or less, in this area would be to have a man come in, say, to age 60 with prostate cancer, and I'd be able to say to him, well, I may not be able to tell you the best treatment because that is an area of controversy, but we could do something to slow this cancer down so it wouldn't impact your lifespan for another 30 years. And if we could just slow that cancer growth by 50%, we could perhaps add another 30 years to that man's life without actually having to go through any major primary treatment. And that would be, to most men at age 60, tantamount to a cure. So progression, I think, is one of the key things we want to consider. And what is responsible for the factors that may inhibit or stimulate the cancer growth? It may be many genetic, a lot of emphasis on genetic genes and being involved in cancer. But it's not going to be as simple as sometimes the papers would have you believe, because it's not just one gene. There are multiple genes that are involved. And the fact is that the implication that it's all genetic falls flat if one looks at the migration study. I mean, these men, when they come from Japan to the United States, they bring their genes with them. So this clearly can't be the major factor, that it can't be genetic. And most of the data would indicate that environmental, and chief under environmental, is dietary aspect. So I'd like to go through with you a little bit about what we know about just one or two areas of diet and prostate cancer, and that is dietary fat, and look at some of the clinical and experimental data. Experimentally, these are some data from our laboratory and others, which were able to show if we take a human prostate cancer, this is a human cancer, it's called LNCAP, which stands for lymph node cancer of the prostate, was removed from a man with metastatic prostate cancer. And if we put this into nude mice, and a nude mouse, as you know, won't reject foreign tissue, and then once the tumor is established, change the diet. Now, those mice that were on the high-fat diet, which is the typical American diet, close to 40% of fat, the tumors grow much faster than they do in the controls. And if we put them on a low-fat diet, the tumors grow much more slowly. The tumors don't disappear, but they almost, this curve, as you go out here, just flattens out, basically. And the tumor just more or less stops growing. And if we look at this in pictures, it's, I think you don't need to be a statistician to see it. If we look at these mice, we ask the question is, how much fat would inhibit this tumor growth? And beyond what cutoff point would the tumors grow faster? And the numbers seem to be, and again, this has been repeated in a number of experiments, that if we keep the amount of fat to no more than 20% of total calories, the tumors are inhibited dramatically. So that these are experimental data. We don't have comparable data in humans. I do some work with Dean Ornish down at UC San Francisco, and Dean feels that 10% it may be more important, since that's what he has used in his studies that show you could reverse cardiovascular disease. But I've been also to that program, and some of you may agree with this, that 10% fat diet's a pretty tough diet to stay on consistently. So 20% is not so bad. And if we move to some of the human data, I like this slide because it really is one picture, 1,000 words category. This shows the age-adjusted death rate from prostate cancer per 100,000 men, contrasted with the dietary fat intake in grams per day listed by country. And we see right up here is the United States and Western Europe, a high death rate from prostate cancer and a high fat intake. And down here, we see the low fat intake, the low death rate from prostate cancer, and there's the Philippines, Thailand, Japan, Taiwan, Sri Lanka, so forth. And the interesting thing is that this could be, I have a prostate, we could put breast or colon up here and it would be almost the same graph. So I think that there's increasing evidence that fat is deleterious to longevity, in terms, at least in terms of prostate cancer. Now I often get asked, well, how much fat should we take? If we should take 20% of total calories in the form of fat, what does that mean, translated into practical terms? Well, the average man with a reasonable amount of activity would take about 2,000 calories a day. If we say 20% from fat, that means 400 calories. And since there are 9 calories in a gram of fat, that's about 44 grams a day is what the average man should take. For women, it would be less because they weigh less. Well, if we look at what we take in, particularly the fast food, let's concentrate here. It's not surprising that a Jack in the Box cheeseburger, 69 grams of fat, the Denny's Ultimate Omelet, 75. You go up here to an Arby's ham platter. In one meal, you shot 2 days of fat intake, 89 grams of fat. And in the areas of the country where they give the Quincy franchise, in one meal, you can shoot almost 4 days of fat intake by one Quincy Steakhouse T-bone. They're not surprising. What is more surprising is to look on your left and look at some of the things that, by terminology alone, you would think are probably pretty good. Nathan's chicken platter, chicken's supposed to be good, but here's 2.5 days of fat intake in one meal. A taco salad. Salad has a nice ring to it. Salad's supposed to be good. But again, 1.5 days of fat in one taco salad. A veggie pizza. Well, everybody knows veggie's good. Veggie pizza. Well, there's 47 grams, and the same thing true for a shrimp dinner. I only put Big Mac here because for years I used to beat up on McDonald's, saying that in Japan, for instance, the incidence of prostate cancer is rising, particularly in the urban areas, and breast cancer also. And I would often say that the increased incidence of prostate cancer in Japan is directly proportional to the number of golden arches as it increases. And those of you who have been to Japan know that the diet is undergoing westernization. And I was surprised to learn that Big Mac's not the worst thing you can do. And actually, if you have a Big Mac, you still have a little bit room left for some more fat in the rest of the day, unlike some of these other things. So I feel sort of guilty about that. What can we say in dietary recommendations? And these are the recommendations that I give to my patients. Low-fat diet. We, in our studies, aim for 15% diet, and we wind up with 20%. Vitamin E, which I'm going to talk to you a little bit later about, 800 units this should be. Soy protein, at least 20 grams daily. Folic acid, 400 micrograms, and 1 multivitamin. And there are lots of things that one could discuss in some of the nutrition. These are the things that I think we have good experimental and clinical data for. Just one area from this list, and I look at the vitamin E and beta-carotene study. It's an interesting study. First of all, it involved 29,000 male smokers in Finland. And based on some earlier studies, smaller studies, it looked like that feeding these men vitamin A would prevent the development of lung cancer. And there's one of the lessons to be learned from this study is you have to beware of small studies and jumping to conclusions about the results of small studies. But it was a program was set up that the groups were divided into 4. they were given beta-carotene, which is a vitamin A derivative. If you take vitamin A, you lower vitamin E. So another group was given a vitamin A and vitamin E. Proper control would indicate that you had some group taking vitamin E alone and then a placebo. They were followed up from 5 to 8 years with almost 170,000 person years. And if you look here on the right first, this study set up to show that vitamin A would protect smokers against lung cancer, showed that smokers taking vitamin A actually had 18% more lung cancer than those who weren't taking vitamin A, and that ended the study, as you might expect. But the interesting thing was that the incidence of prostate cancer in these men was down by 1/3. And these data have been not repeated in a study of this magnitude, but in smaller studies in the laboratory. And I also feel that there's enough data to recommend vitamin E as a potential, not necessarily a preventive, but slowing the growth of prostate cancer. So that's nutrition. What else do we have out there in this area of complementary medicine? Exercise. Well, can we focus that a little bit more over there? This is an interesting study. It was published in the Journal of the American Medical Association last year. I'm going to intersperse my comments not only with cancer, but also some of the other things. This shows, as you know, type 2 diabetes, the most common adult onset diabetes, is thought to result from the fact that even though we may produce as much insulin as we always did, we get less sensitive to it, build up resistance so that we don't get the same effect. The interesting thing is when that happens, our body responds by producing IGF, which is an insulin growth factor. So we get higher ratios of IGF in our body. And there's been a number of studies recently indicating in the case of prostate cancer and also breast cancer that IGF may be stimulatory to breast and prostate cancer. So that the pertinent thing for this discussion is that this is a study, very well done study, showing that if one exercises, you can actually increase the sensitivity to insulin in the body. If you make the body more sensitive to insulin and use more insulin, you decrease the insulin growth factor. And that this is giving more insulin won't help these people, but having them do more exercise will actually increase the sensitivity, make the insulin that the body does produce more effective, and blunt the effect of IGF, and may have an advantage in forestalling cancer. This is some studies looking, this was done 50 years ago almost, the influence of exercise on the growth of transplanted rat tumors. And over here, this was a sarcoma, a very rapidly growing tumor. You see the controls had a tumor weight of 66 grams, but the animals that were given the tumor at the very same time and yet were exercised had a tumor that was 1/30th the size of the controls, showing the beneficial effects of exercise in inhibiting the growth of this tumor. And it's also interesting to note that the animals that had the exercise and the tumor were not wasting away, because we know that losing a lot of weight will slow the tumor growth, but they actually gained more weight than the controls who had the bigger tumors. So I think, again, there's clinical and experimental data to substantiate the impact of exercise. But to put it in a more clinical perspective, there are two recent studies published last year, or this was 97 in JAMA, looking at activity and mortality in postmenopausal women. And in this study, what they did is ask women how often they exercise for periods of 30 minutes. And the exercise could be as little bit as walking. It wasn't really a major workout. But then looked at the death rate of these women using those who rarely or never exercise as the control. Were able to show that women who exercise 4 or more times a week for just 30 minutes would have a death rate that was about half of those who never exercise. And an even more impressive study, although the numbers are smaller, but it was a prospective study, was published in the New England Journal last year. In 707 men, they actually interviewed these men 12 years before the study was published and found out how much activity these men were doing and related this to walking. And they broke the men down into groups that did exercise less than a mile a day. In a sense, they took various equivalents of exercise, and they broke it down to those who had less than a mile walking a day versus those who walked more than 2 miles a day, and followed them for 12 years, and then took the death rates and the overall cancer death rate. You can see the death rate in those men who walked more than 2 miles a day was 50% that of those who walked less than a mile a day, and the cancer death rate was down by 2/3. Now, if this was a new drug or a new procedure, this would be on every television station and every radio and the front page of every newspaper in the country. And here it is. It's some of the most powerful data we have on the benefits of exercise. And because it's not taking a single pill, but it's changing our lifestyle, we don't go into it as much. Moving on, what about stress reduction? I mentioned before, I think the benefits of meditation and yoga are impressive. The question has always been raised, does stress cause cancer? And while there have been a lot of people who have thought along these lines, we never really know the answer to this. We do know that stress can alter immune function, that the immune system can regulate tumor growth, and both the type and magnitude of immune changes can influence how fast the tumor grows and whether or not it will metastasize. We also know that acute stress, such as parachute jumping, that's assuming the plane's not on fire or something like that, but I mean recreational parachute jumping will increase natural killer cell function and increase the immunity. But chronic stress, such as that accompanies chronic disease, will decrease natural killer cell function. And a study came out in the American Journal of Psychiatry a little less than 2 years ago now that made an attempt to answer this question. And what they did was set a prospective study, 93 men who were HIV positive but did not have clinical AIDS. And this was a 42-month study. Each of the men got a medical and psychological assessment every 6 months using state-of-the-art tools to assess stress. And then they did an analysis between stress and disease progression. Was able to find that those with a higher stress level had a much higher incidence of disease progression. And in the most severe stress level, there was a 4-fold increase in the incidence of disease progression. And here the endpoints were very easy because it was conversion from HIV positive to clinical AIDS. And this is really the first observation prospectively that stress can accelerate cancer, and agrees with some animal experiments in this area. We still don't know whether stress causes cancer, but certainly can make cancer grow faster, it seems. Moving on to things like group support, spirituality. This is a book that was recently published by Dean Ornish, and it's an excellent book entitled Love and Survival, the scientific basis for the healing power of intimacy. And Dean gives this quote in the book, which I like: "I am not aware of any other factor in medicine, not diet, not smoking, not exercise, not stress, not genetics, not drugs, not surgery, that has such a major impact on our quality of life, incidence of illness, and premature death from all causes." And he's speaking about the relationship and love and intimacy. And to back this up, there have been a number of studies, it's 8 large-scale studies over this 15-year period, wide geographical variation throughout the world, showing a 2 to 5 times increased risk of premature death in those that were socially isolated. And I like this study, particularly when I'm talking to medical groups, because it was a study done in the 1940s, 1,100 male medical students at Johns Hopkins. Before the women get up in arms and say, how come no women were in there? Well, there were no women at Johns Hopkins in 1940. So that's why it was restricted to male. And they were attempting to study the hypothesis of whether or not the quality of human relationship was a factor in the development of cancer, and used this closeness to parent scale. And the men who participated in this, those that are still alive, are being evaluated even now. They found that the best predictor of cancer up to 5 decades later was the closeness of the father-son relationship in early life. And this didn't diminish over time. It was true in the first decade as well as the 5th decade, and it was not explained by other factors, including smoking, drinking, and radiation exposure. Now, Tony handed me something right before we started about the support that you all have here, and I think it's impressive to see some of the support programs for cancer patients. And I know there's a support program that had mentioned Dr. David Spiegel's work in a group support. David Spiegel is at Stanford, psychiatrist that started a study basically like Descartes to prove that psychological impact would have no effect on a physical process such as cancer growth. So he took women with metastatic breast cancer, and in one group, which were 50 women, gave them 1.5 hours a week of support, social group support run by a psychologist. And the other group of 36 women in the controls had the same kind of care, standard oncologic care, without the support. And to his credit, followed these women and actually waited 10 years to publish these results, was able to show that in those women who were in the support group, the survival was twice as long as those who were in the control group. And if one looks at the graph on your left, all of the women in the control group were dead within 42 months with a mean survival of 18 months, which is what would be expected with metastatic breast cancer. But in the treatment group, even at 10 years later, there was about 10% of these women that were still alive. And they didn't continue the treatment. It was just one treatment, 1 year of this treatment. And once again, this is one of those things, if it was a drug, it'd be all over. You know, and here's something that has doubled the survival for breast cancer, and we tend to think, oh, well, since it's not taking a drug, it's really out there in that fuzzy world, and it really doesn't mean anything. But it's not related, it's not totally, these social factors are not totally isolated among humans. And I like this study on your right, has nothing to do with cancer, but it's a study that was published in Science in 1980. And in those days, there was a lot of research going on causes of high blood pressure. And this was to look at the effect of arteriosclerosis and on coronary artery disease. And the study was set up so they would feed these animals a diet that was very high in cholesterol. And then after a certain period of time, they would sacrifice the animals and actually measure how much coronary artery disease they had. And it turns out that it was a small room, and the rabbit cages were stacked from the floor to the ceiling. When it came time to sacrifice the animals, they found that when they looked at the animals in the high cages, it was not surprising that they all had severe coronary artery disease. But as they went down towards the lower cages, there was a 60% reduction in the number, and the cardiac disease was much less. They couldn't figure this out, and they did a series of experiments, and I guess the reason it was published in Science, which is one of the premier journals, was what they found out was the only difference between these animals in the high cage and the low cage is the woman that came in to feed these animals couldn't reach the rabbits in the high cage, so she just pushed the food through the cage. But the ones in the low cage, they were such cute little things, she'd take them out and play with them and pet them. And that was the only difference. And that was the difference between 100% and 40% cardiovascular disease. So there is something that I think we can't quite quantify, but it's true. What about symptom control? Well, I'm sorry, I hit the wrong button. Acupuncture. When I was in medical school, many of acupuncture was thought to be really nonsense. But now we've begun to appreciate more about pain and suffering, and knowing that pain is a physical process, but suffering is the perception of that experience. And it's growing increasingly evident that one can change the perception or the suffering, even though the pain may still exist. We now know, as a result of a consensus conference held 2 years ago at the National Institutes of Health, that there are documented benefits from acupuncture in controlling certain types of pain. I've been very impressed in my own patients with the effects of acupuncture in decreasing the nausea and vomiting associated with chemotherapy. And certainly there are good data to show that acupuncture can be beneficial in asthma. And recently at the AUA, I was talking to Jerry last night, there's even some data showing acupuncture can help urinary control in older women. And you know, we can't understand, we can't explain this in biomedical or Western terms, but I think the studies look pretty convincing. But what about aromatherapy? Now that really is something far out, you would think. Well, look at the right here. This is a study that is well known to psychologists and people in animal studies. It's called the Bruce effect. If you take a male and female rat and put them together when the female's in heat, not surprisingly, rat pups will develop. But once the female is pregnant, if you take the male out of the cage, the pups will be reabsorbed. And they won't, the fetus will be reabsorbed. Pups will not. If, when the female is pregnant, you separate them, the male and the female, by a wire partition so they can still see each other, odors can go back and forth, but they can't touch, pups will result. But if you then take the pregnant female and separate her from the male by a glass partition, they can still see, they can't touch obviously, but no odors go back and forth, the pups will be reabsorbed. And this is an example of the so-called Bruce effect, and it's thought to be some undefinable substance going back and forth, a pheromone in the odor between the male and the female. Pheromones we've heard about for a number of years, airborne chemical signals, odorless, released into the environment, thought to affect the physiology and behavior of other members of the same species, and they've been used sometimes in not too successful experiments in mosquito control and things like that. Well, again, this is one of those areas that is hard to define. Yet at Memorial Sloan Kettering, some of our folks did a study a number of years ago to try to make it easier on patients going into an MRI examination. If any of you have had that, you know how claustrophobic that big tube can be. And they spread various types of odors in the MRI and found that they could markedly, almost eliminate the claustrophobia of people who had demonstrated claustrophobia before by actually spraying some lavender into the MRI machine before they went in. But again, it's not been really documented how this happens. Well, last year a study came out which looked at a phenomenon that I think every woman in the world probably knew, and it tried to investigate this phenomenon. If women live together in boarding school or convents, colleges, they tend to synchronize their menstrual cycle. And I had never heard of that, and the fact that every woman in the world knew it and I have never heard of it was no surprise to my wife at all. She thought that was consistent with past experience. At any rate, what they did was they took a group of women donors and they had them wear an axillary pad for 8 hours. And then they took these pads out and cut them up, put a little bit of alcohol on them. In order to determine accurately where these women were in their phase of their menstrual cycle, they measured LH in the urine samples, basal body temperature, and progesterone, and did the same thing on a group of women who would be the recipients. And were able to show, when they took these pads that the donors were wearing, and they simply took part of this pad and they wiped it above the upper lip of the recipients, they were able to show there was not one pheromone, but actually two. And one of these would increase, lengthen the time of the menstrual cycle, and this is for 2 months afterwards, and the other would decrease. And the interesting thing, which I found quite interesting, was if the donor was in the pre-ovulatory phase of her cycle, and the pad that she was wearing was put on the skin of the recipient, it shortened the cycle in the recipient. And if the donor was in the ovulation or post-ovulatory phase, it lengthened the cycle in the recipient. In other words, it was an attempting to get both of the menstrual cycles in sync. And this was the first definitive evidence that pheromones exist in humans, and that the timing of ovulation in the recipients is manipulated by pheromones. And this also was published in Nature. And again, all of these things that have been citing to you are published in reputable journals. These are not in throwaways and things like that. Moving on to getting the end here, herbal therapy. That's not new, and I like this quote from Ezekiel. And on the banks, on both sides of the river, there will grow all kinds of trees. Their fruit will be for food and their leaves for healing. And this goes back to Old Testament time. And again, we never thought very much about herbs, but we do know that in the treatment of benign prostatic hyperplasia, saw palmetto is as effective as Proscar, the Merck drug, and it's a lot cheaper. That in treatment of depression, St. John's wort, is as effective for moderate depression as many more expensive pharmacologic agents. And the interesting thing for the urologist in the audience is a herbal compound that I think is really interesting, and it's called PC-SPES. SPES is Latin for hope. PC stands for prostate cancer. And it's a combination of 8 herbs. Not surprisingly, it's a mixture. Article of faith among Western chemotherapists that you never use a drug in combination unless it has shown some effect as a single agent. That's not true in traditional Chinese medicine, and it's very rare for them to use a single herb. And the idea is that many Chinese herbal remedies, according to the TCM masters, are compounds that in and of themselves will have no effect, but when mixed with other compounds, there will be a synergism between. So it's a different approach than what we use. Well, PC-SPES is these 8 herbs. Licorice and ginseng are known to have effect as phytoestrogens, meaning they have an effect like estrogen. And this was the darling of man-to-man groups and us two support groups. So, I mean, I never heard of this until patients started telling me about it. And there was an article in the New England Journal last year which took this to task. It was a series of articles actually commenting negatively on complementary medicine. And it was interesting that one of the things they were talking about was there were so much anecdotal reports in complementary medicine and not real science, which is certainly true. On the other hand, the article about PC-SPES was an anecdote of 8 cases with adverse effect. And most of the adverse effects were related to estrogenic effects. And we knew that, as I mentioned from the compound, that there are phytoestrogens in this thing. But it may not be all bad. Maybe one of the reasons that the incidence of clinical prostate cancer is so much less in Japan and Oriental countries than it is in the United States is the fact that those men take more soy and have more. Soy is also a phytoestrogen. You may have seen some articles in the press not too long ago. There was a study came out showed that hot flashes in postmenopausal women in Japan are much less than in the United States. And it's thought that's because soy constitutes such a large part of their diet that it's basically estrogen replacement therapy almost, and they have very few hot flashes contrasted with women in the Western world. But we know that PC-SPES, despite being an herbal medicine, in addition to the phytoestrogen effect, it inhibits BCL2, it upregulates the BAC program, and has a powerful influence on inducing apoptosis in prostate cancer cells. And at the ASCO meeting, which just ended yesterday, I guess, in Atlanta, there were a number of studies. This came from Valhalla in New York, and they showed that this PC-SPES inhibited an animal model of prostate cancer that is not sensitive to hormones, the Mat-Lai-Lu. It's a very aggressive tumor. And that the growth was inhibited by more than 90%. And this is a very interesting study done at UC San Francisco by Eric Small and his group. And the study is just underway. They only had 24 patients that were followed for more than 1 month. But they were patients with advanced prostate cancer. And there were 12 in the hormone-naive group, and 9 of the 12 dropped their PSA by more than 50%. And that would happen with DES also, though that's not too surprising. What is surprising that there were another 12 that had hormone-refractory prostate cancer. They had orchiectomies or had failed hormonal therapy. And 9 of the 12 in that group also dropped a PSA by more than 50%. And that's purely not just the estrogen effect. There's another study that has not yet been published, but it's coming out. It was done in Germany. They followed 16 men with hormone-refractory prostate cancer. The initial PSA was 108, and all these men, again, had failed hormones. In 15 of the 16, there was a PSA decrease, and within 3 months, the PSA decrease was in the order of about 60%. They also measured quality of life and showed there was a marked decrease in the amount of pain and narcotic intake and increased quality of life in taking this herbal remedy. this was the article from the New England Journal, caution that it does have estrogenic activity, and showing that some of the effect may be due to the estrogens because the men got breast tenderness and loss of libido, and one man had a superficial venous thrombosis. But again, the approach and the tone of this article, and I've spoken to Bob DiPaolo about this, was you shouldn't use this because it has toxicity. And what chemotherapy do we use that has absolutely no toxicity? And I think the fact that this has demonstrated some effect in hormone refractory prostate cancer, and the urologist in town, if you haven't had patients come in and ask about it, you will have them come in and ask about it. I can guarantee you that. We don't know who will respond. We don't know how long, we don't know whether the effect on PSA really means it having an effect on tumor. We don't know how long will the effect last, and we don't know all the risks. But I think it is a unique agent, and we clearly just can't dismiss it out of hand because it's an herb. Sir Dennis Burkitt, who is known for his studies in colon cancer, had this comment that I like: not everything that counts can be counted. And a number of studies have shown that there's a feeling that many of our current treatments are ineffective despite the tremendous advances that have been made. And a lot of this is unrealistic expectations. The philosophy, well, we can put a man on the moon, why can't we cure cancer, that kind of a thing. It's true that we need more evidence-based therapy, but also what we practice as physicians is not entirely evidence-based therapy either, and it's been estimated that no more than 15 to 20% of what we do is really evidence-based therapy. And also, the point also is we have to recognize that this hocus pocus is not limited to alternative treatments. This past week at ASCO, there were 4 studies shown, 4 randomized studies, that there was absolutely no benefit in using autologous bone marrow transplant in women with metastatic breast cancer, and yet that still is the standard in many parts of the country and by many chemotherapists. And it's the idea, well, we have nothing else to do. We can always take another bottle off the shelf or give more radiation or doing another form of surgery. And I think that as a patient, I've come to appreciate the difference between curing and healing. Curing, as you know, means we eradicate the disease. And I'm sure we all know people who have been cured of their disease but have not been healed. They're totally incapacitated emotionally and psychologically because of the fact that they had this cancer and they're always waiting for the recurrence. Healing, on the other hand, means that even if you can't cure the cancer, you can come to grips with this and recognize that at times many of us may have to face the choice between expanding life or extending life, and that the best form of approach to someone who has cancer and whom there's no other standard treatment may not be to take that other bottle off the shelf or to give more radiation or chemotherapy, but sit down and talk to that patient and decide what he or she wants and what time is left in their life. And in my own case, I didn't want to be strapped to an IV pole someplace for a long time. And the last 2 years, since I made this decision, I've had the occasion to, I like to trek, and trekked in Patagonia and Alaska and learned to scuba dive and things that I never would have been able to do had I opted to go ahead with measures that may or may not have extended life. But yeah, I don't say that's the right way to, I think that my take-home message is that different strokes for different folks, and we as physicians should not feel that our goal is always to extend life no matter what, because sometimes expanding life is more important than actually living a little bit longer. And I'd like to close with this quote from Sir William Osler, who is maybe the wisest physician who ever lived, and it puts into perspective how we ought to look at these things and how it's important to have an open mind when we're approached by patients or studies on complementary medicine. Dr. Osler said, "The philosophies of one age have become the absurdities of the next, and the foolishness of yesterday has become the wisdom of tomorrow." And the problem is that I think whether we're talking about alternative medicine or allopathic medicine, at the present time, we don't have the evidence to know what is the foolishness of today and what will be the wisdom of tomorrow. So thank you very much for your attention.